Assalamu alaikum. The clinical day, the first scenario. Mrs. Sophia Adam, 27 years old lady, presented with severe headache. Please sit with her, take history, examine, and address her concerns. Okay. Ready?
ماشي يا باشا. اوكي ريدي يا باشا.
Yes, I'm sharing the timer. Yeah, here you go.
Hello, good morning. I'm Dr. Ismail, Senior House Officer of the on duty now. Am I talking to Mrs. Sophia Adam, 29 years old?
Yeah, I'm 27. Yes, I'm Sophia.
May I ask you, today we will discuss your health issue and you will examine you and address your concern. Is that okay with you?
Yes, doctor.
What brought you to the hospital today, Mrs. Sophia?
I came with this headache. I have very severe headache. That's why I'm here.
Hello?
I have very severe headache. That's why I'm here.
Hello?
Okay. My voice
Yes,
is not
Dr. Mahi. Yeah, we can hear Dr. Mayada. I think the problem from your side, Dr. Mahi.
Hello?
You can hear us? Dr. Mahi, check your internet, please. Check your internet. The problem from your side. I pause the timer. We'll wait for you.
Okay. خلاص يا باشا. Okay. Continue.
Yeah, you can hear us?
Yes.
Okay, go ahead.
Now you can hear me?
Yes, doctor.
Okay. So I came to the hospital because I have very severe headache.
I'm sorry for that, Mrs. Sophia. When this headache started?
I noticed this headache over the past few weeks. However, nowadays it's become more severe. That's why I feel like, no, it's enough. And I came to the hospital. I come to the hospital.
It is present all the time or on and off?
Most of the time, most of the day. I try to take some pain medication. I already have a migraine, headaches with migraines, and I'm using a lot of medication for that. But this is different from my usual migraine, I can say.
I'm sorry for that. But you told me it is present all the time or most of the day.
Most of the day.
Okay. Where is the site of this headache?
You know, doctor, when the lemon squeezer, I feel like my head is squeezed, completely squeezed. So all over.
So it's where it's a site, in the back or the side or front of the head?
Like you are squeezing a lemon.
Hello?
Like if you are squeezing lemon, it's all the heads. I can't, all over.
Hello?
Again, Dr. Mahi, I think the problem.
I ask Doctora, where is the site of this headache?
She said all over.
All over. Okay. What is the score of 8? Of 0, no pain, and 10 is severe? How you can scale it?
I can scale it 10 out of 10. For
10?
me, really, it's really severe. Yeah.
Sorry for that. Do you want a painkiller right now?
Yeah, they just give me some morphine. That's why I come talk to you. I'm okay now.
Okay. Do you notice that anything increases pain? Like movement or cough or sneezing or leaning forward?
I know, like small words at night, in morning, or when I lie down, it mainly be like words.
It increased by leaning forward?
Yes.
Okay. And what improves this headache, Mrs. Sophia?
I'm trying some pain medications. I think it's relieved it a little bit, but not completely improved.
Do you feel light increase the pain or make you uncomfortable?
Yes.
Do you prefer to stay in dark room?
Uh, no, no. But
Mm.
the area is quiet and everything. I feel more better. As I told you, doctor, I had migraines before. The migraines, I previously I feel like in the dark room I feel more better. But in this
But
time,
this headache or new pain, it is different in the nature from the migraine you have before. Is that
yeah,
right?
yeah. It's still, even if I'm in dark area again, I have the headache.
Is that right, doctor?
Yeah, it's different.
Different. Okay. Do you feel any stiffness on your neck?
No,
Uh, this pain in your head, where it moved to?
uh, it's just in my head.
Just in your head. Okay. Um, may I ask you, do you have any recent change in your body temperature?
No,
Mm. Any recent infection in your mouth or your throat?
no,
Did you do any dental procedure recently?
no,
An infection is your nose or your sinus?
no.
Okay, okay. May I ask you some questions, Mrs. Sophia? Do you have any recent changes in your body weight?
It's no change, but I look like this for a long
Hello?
time. Hello? It's a problem from my side.
Sorry, Dr. Mayada?
It's
Hello?
a problem from my side, or everyone
No, no,
from.
no, no, we can hear you. I think from Dr. Mahi's side.
معلش شبكة النت بتاعتي اتغيرت اليوم.
No problem. You can hear now?
Yes, yes, yes.
Yeah, go
I
ahead.
ask,
Continue,
I
please.
ask you, do you have any changes in your bowel habit?
No,
Okay. Any difficulty swallowing?
no,
Hello?
no, no, no.
Dr. Mahi, she's saying no. Okay, Dr. Mahi, we can wait for you. You can disconnect and join back.
Yes, yes. مش عارف اشتغل السيناريو ده بصراحة.
Is it internet problem or
Yes,
something
internet.
else?
Yes, internet problem. لو أي حد تاني عايز
Check.
ياخد السيناريو.
No, 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 no. Continue. It's yours. Continue, please.
Okay, okay. Uh, I asked you, do you have any changes in your bowel habit? And you said no, okay?
Dr. Mayada.
No, no, yes.
Yeah.
Any change in your water work?
No change.
Okay, okay. Any joint pain?
No,
Any skin rash?
no.
May I ask you, do you have any past medical history I should be aware of apart from this migraine?
No.
Uh, okay. Um, I wanted to ask you, Mrs. Sophia, you told me you have migraine and you take painkiller for it. Do you use how many days per month you use this painkiller?
Not a lot. I like when I have the migraines, and the migraines it comes over several days over the month, and then disappear. Uh, it's okay. So I'm not taking medication a lot.
What is this medication, Mrs. Sophia?
I use paracetamol and sometimes I can use naproxen, uh, this type of pain medications. Not most of the day.
But this medication did not exceed the 10 to 15 days per month.
No, no, because my migraines is not that frequent.
Okay, okay. I'm sorry to ask you this question, Mrs. Sophia. Do you have any recreational drugs?
No,
Okay. Um, do you have any family history of similar condition?
no,
Any family history of cancer?
no.
Any family history of chronic disease?
My mom have diabetes, but nothing else.
Okay, okay, okay. For any recent travel for you, Mrs. Sophia?
No.
Okay. Sorry to ask you this sensitive question. What about your period? It
My
is,
period,
it is regular?
it's it's not that regular. It's heavy periods.
And regular?
No,
Uh, uh, do you use birth control pills?
yes,
Mm, okay. Any miscarriage before?
no,
Okay. 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 May I examine you while I'm taking history from you?
yes, of course.
But first, I wanted to ask you, do you smoke?
I do, I do. I
How
smoke
many cigarettes per day?
around 5 to 6 a day for the past
For how?
5 years.
You know, Ms. Sophia, smoking is injurious for health, and I advise to stop smoking. Okay.
Okay.
Do you drink alcohol?
Social.
Okay, okay. I wanted to examine the patient.
Okay.
I want to ask you first, what is the vital signs?
All the vital sign is normal.
Okay, okay. Then,
Apart from blood pressure is a little bit in the high side, is 140.
okay, okay. Okay.
Mm.
See, then I will see the hand for any abnormality about pulse, tremors, tone power in the
No,
upper limb, barometer,
normal.
barometer
And
drift. No.
the power
Okay.
is normal, tone normal. No
Mm,
change in sensation upper limbs.
okay. Okay. Then I will do flexion to the neck. Is there any abnormality?
Sorry,
Movement of the neck flexion,
normal.
normal. Okay. Then I will do tone and the plantar in the lower limb.
Normal.
Okay. Then I ask Mrs. Sophia, do you have any blurring of vision, any vision problem?
Yes, I feel like I see objects.
Hello?
Yes, I've seen doubling of vision.
She see double, Dr. Mahi.
Hello?
Dr. Mahi,
Yes, yes.
she
I
said
asked,
she see double.
she saw see double vision. Okay. Um, okay, so I will check the H-shape movement of the, okay.
Hmm?
Um, when you see, when you feel pain or double vision, let me know, okay?
Okay. So what? Yeah, she can see double vision.
Hello?
Yeah, she can see double vision on abduction of the eye.
Yes, yes. I ask, uh, I ask, I will do each shape movement. If you see double or pain, tell me, okay?
Okay.
She said
Uh,
there is double vision while abducting the eye. She said that.
and to the left side or to the right side?
in the sixth cranial nerve.
Which left or right?
No, not in the distribution of the sixth cranial nerve.
Left six cranial
Ah,
nerve or right?
okay,
Which
sorry.
eye? Which eye? Which eye?
Which um, left eye.
Okay. So if I will cover left eye, the double vision disappear,
No, it's still
not disappear. Okay.
both.
Then I will. Do you see my face properly, Mrs. Sophia?
Yes, I can see your face.
Okay. Then I offer to do Snellen chart to see the visual acuity. Is there any abnormality impaired or same?
No need, they say.
No need. Okay. I offer also to do visual field. Any changes in the field?
She see just double vision in the distribution of the sixth cranial nerve. That's it. The main.
Okay. Okay. I offer to the examiner to see fundoscopy also.
Yes, do fundoscopy.
Hmm. Okay. We'll do fundoscopy to see is there any papilledema
There is.
in the left eye?
Yeah, both
Hmm.
eyes.
Both eye. Okay. I wanted to ask you, Mrs. Sophia, do you lose your conscious level in this week?
No,
Okay. Any shaking of your body?
no,
Okay. Do you have any past history of cancer or you eh, hmm?
no cancer.
Okay. Okay. What is your body weight, Mrs. Sophia?
She's 30. BMI.
30. And you use birth control pills for how many years?
Since I was 18.
18. But you don't use any medication for acne before or any derivatives of vitamin A?
I have this acne and I use tetracycline.
Uh, uh, when this medication you use, you are using it nowadays?
I start using them over the past 1 month.
Okay, okay, okay. Um, may I ask you, Mrs. What is your concern, Mrs. Sophie?
It's headache. What's going on?
Mm, I appreciate your concern, Mrs. Sophia. You have a condition named as idiopathic intracranial hypertension, increase in the pressure inside your brain. And this is due to use of this medication for acne. And for also, it is aggravated by use of birth control pills. Uh, what I will do now, I will admit you and I will run for you blood test and I will do urgent imaging for your brain. Then I will inform the multidisciplinary team, including the nerve doctor, to after release of this investigation, and then I will update you by the management. Okay?
2
Okay.
minutes left.
Do you have any other concern?
Yes, doctor. Regarding my work, I'm a bus driver.
Yes, yes. I'm sorry for that. I wanted to tell you, to ask you how much this headache affect your job and your daily activity?
Over the past few weeks, I just taking leave, and
Uh,
it's affecting my work a lot. And they asked me even to quit my job because I'm taking a lot of leaves.
I'm sorry for that, Mrs. Sophia. At the moment, we will advise to stop driving, and I will give you sick leave until we solve this problem. Okay?
Yeah, but doctor, I am the main carer of my family.
You are what?
I am the main care of my family. I have one kid. I am a single mother, and I'm the main care of this one kid, and for my father and mother who are blind.
I'm sorry for that, Mrs. Sophia. We will involve the social health worker for help as regards this issue. But for your case now, I'm sorry to tell you this case is serious and we should admit you and possibly after take opinion of the team to do what name as lumbar puncture. So from your back to decrease this pressure. And they want to also to run a urgent aim scanning for your head. So we cannot discharge you at this serious problem, but we will involve the social health worker for help as regard caring for the kids and your father and mother. Okay?
Okay. Okay, doctor.
Okay, time is up. Examiner question, Dr. Mahi. Dr. Maida, you can start.
Yeah. So present your case.
Okay, Mrs. Sophia?
Hello.
Dr. Mahi, present your case. Dr. Mahi, I think disconnected. Wait for him.
Sorry, Mrs. Sophia, you heard my addressing your concern?
Yeah, time is up, Dr. Mahi. So we'll start examiner question now. She heard you. Okay?
Okay.
Now present your case.
This 29 years old female patient with past history of migraine and patient on painkiller, but recently she has acne and received the medication, vitamin A derivatives for acne, and also she is on birth control pills, oral contraceptive pills for a long time, presented with new change, severe of headache, accompanied by papilledema bilaterally and blurring of vision with diplopia, but there is no hypotonia or any pyramidal affection, only six cranial nerve palsy. So this patient possibly has idiopathic intracranial hypertension.
Mm-hmm. Okay. So in this case, uh, what you will do? What's your management plan?
We will admit this patient and we will do for her basic investigations and urgency CT brain. Then I will form the multidisciplinary team for doing lumbar puncture to decrease.
Who is the multidisciplinary team you will discuss this case with?
Nerve doctor, neurologist,
Mm-hmm. Mm-hmm.
occupational health worker, and the specialized nurse.
That's was in London.
Mm.
Yeah.
Okay.
I told you multidisciplinary team, including neurologist, uh, occupational health worker, and social worker, and specialized nurse.
Mm-hmm. Okay. So for how you said to this lady to not drive. For how long she needs to stop driving?
She will stop driving until normalization of this pressure and the relief of this papilledema.
Mm-hmm. Okay.
Will be decided later by the DVLA.
Mm-hmm. Okay. So she need to inform the DVLA.
Yes.
Okay. What's regarding she's taken oral contraceptive pills for birth control. How she can, what other birth control or what's your advice regarding this part? How you can advise?
I advise her to go to the يعني fertility doctor or the woman doctor to change this mean
Put this, your team, yeah, in the multidisciplinary team.
woman
Need
doctor.
involve the woman doctor in. Yes. Okay. Good. Thank you. That's
Still 2 minutes remain. How the investigation he mentioned? The image?
What
Yes.
is-
Image, the investigation CT scan, lumbar puncture. And okay, what's the treatment? If this a case of idiopathic cranial hypertension, what is the treatment?
treatment is only stopping this medication and also oral contraceptive pills and do therapeutic lumbar puncture. Then if still this painkiller also for the headache and if still this measures not improving the headache, we will add small dose of corticosteroid.
Corticosteroids?
Mm.
Okay.
But this is the second line. First line to take these measures: stop oral contraceptive pills, stop the vitamin E derivatives for acne, and do therapeutic lumbar puncture. Then next step is steroid, small dose if still patient has headache. Uh, if you still also have headache, there is something named as optic nerve fenestration.
Mhm. Okay. Okay. This is the treatment. What is other possibility apart from idiopathic intracranial?
Maybe this is attack of migraine, not intra-idiopathic intracranial hypertension. And I also, because patient has severe headache, 10 by 10, possibly subarachnoid hemorrhage can be.
Mhm.
I also, in this young age, idiopathic cavernous sinus, severe sagittal sinus thrombosis, but against this, there is no family history or history of blood clot or miscarriage before. No even
Mhm. Hello?
Dr. Mahi.
yeah. I asked you don't hear me? I told here differential diagnosis migraine, sinus thrombosis, but against this, I tried to take history to rule out thrombophilia screen. There is no any evidence. Subarachnoid hemorrhage because patient told me severe headache. Score 10 by 10. So subarachnoid hemorrhage should be also ruled out in this case.
Mhm.
I asked about fever and any recent infection to rule out cover.
Mhm.
What else as a cause of acute headache? Severe headache. Dr. Mahi.
She did not hear. I told this differential diagnosis. Hello?
Yeah, we heard all of them. What else? One more differential.
I I I said all.
One more. I need one more as acute.
Subarachnoid, last one I told.
Okay,
Subarachnoid.
subarachnoid already, yes, agree.
You said subarachnoid hemorrhage, and you said as
Venous
well.
sinus thrombosis and cavernous sinus thrombosis. One more. Meningitis, you want to add?
I think your connection today is very bad.
Yeah, very far. Okay. Please, Dr. Mayeda, you can comment, and I will ask Dr. Mahi to disconnect and join back.
Okay. Time is over for
Yeah. 7 minutes now.
Okay. So I think you did very well. You first the presenting complaint. It was Okay, yeah, you do all these things. The only thing that's the visual disturbance, you take it long time to take to ask about it. But it's a very important associated symptom from the early because this patient headache is 10 out of 10. So this is standard club headache. From standard club headache, you need to roll out first the visual disturbance because it will give you a lot of information in this patient. You ask about seizure and fever, so that's very well. And you ask about the menstrual and contraception, and this went very nicely. And you also uh, um, make like comparison between our previous migraines and this type of headache, so you understand that there is a difference between the previous headache and her migraine. The only thing that her blood pressure is on the higher side. It is 140 for this young lady, still high blood pressure. So still we need to roll out there, and she's using oral contraceptive pills. It's still, I think, the venous sinus thrombosis will be one of the differential because still she's taking oral contraceptive pills. Even in the history, she didn't have miscarriage. Maybe she will have miscarriage with the age. She's still young. So still we need to do a CT venogram to roll out there is no a cavernous sinus thrombosis because this is one of the important things. It's specifically that she has six cranial nerve palsy. So we need to roll out this very importantly. Um, for the treatment, I think you mentioned that hydrocortisone. I'm not quite sure about hydrocortisone. I think we give acetazolamide for this for increased intracranial pressure, idiopathic increased intracranial pressure. I'm not quite sure about hydrocortisone because hydrocortisone itself can cause one of the one of the cause of idiopathic increased intracranial pressure. Correct me if I am
Yeah,
wrong.
yeah, it's one of the cause, and at the same time, it's one of the management plan.
Hmm, okay. Otherwise, I think you did well. The only thing
Mhm.
that's a concern, the driving, and very important in this case, is specifically that she is a heavy vehicle driver. So that means she needs to stop, and you'll be very serious that she stop driving and inform the DVLA. So one of the important things that you need to tell the patient to know exactly what's her job because it's safety for the patient. Okay. I think yeah, this is what I need to say. But
Yeah. Okay, Dr. Mayada, thank you so much. We did this case maybe I think last week or the week before. It was the same presentation headache. But my question, Dr. Mayada, IIH, is it one of the cause of acute headache or as a chronic headache?
chronic headache, she said that
Yeah,
over the past few
perfect.
few weeks.
Exactly. So at least to be subacute, not as
Mm.
acute one. I don't know if Dr. Muhi asked about the onset.
He asked, and I told him this over the past few weeks.
Yeah, okay. So now we are targeting the causes of headache in subacute form. You can add the acute as first last weeks or last days. You can ask about the alarming sign to rule out the horrible cause of meningitis like subacute hemorrhage, which is sorry the horrible cause of headache. And the most and the worst headache ever in cases is subacute hemorrhage. And since you have 10 out of 10 scale of pain or headache, you have to suspect the subacute hemorrhage. If you can roll it out, think about other causes. But before that, you have to analyze the headache well: the onset, course duration, the timing, the scale, and the nature of the headache. Dr. Mayada already mentioned it's all over. So it's something with increased intracranial pressure. I will focus on the cause of headache with increased intracranial pressure, whatever the headache is. We have in our differential, I wrote it before, headache with increased intracranial pressure as acute form meningitis and subarachnoid hemorrhage, venous sinus thrombosis, cavernous sinus thrombosis, space occupying lesion. Okay, if you go through all question, you will know what the case you have. Dr. Mohi was confused. I agree for being difficult to go through the case.
Sorry, Dr. Bassam.
Yes. Hello? Okay. I advise you, Dr.
You
Mohi.
mentioned is space occupying lesion. This is
Yeah.
acute.
Space occupying lesion will be acute on top of chronic. Yeah, this patient is having headache for last maybe weeks or maybe months as migraine, but nowadays or the last weeks being more severe. So space occupying lesion, one of them. Still, the space is enlarging and making the pressure increase. Maybe rupture of vessel or the size being more enlarged to cause severe headache. It's a vague onset. It's not acute one and it's not chronic one classic. There is acute on top of chronic. Agree?
Okay.
So the nature change, of course. So it was migraine and the change to IIH. But I believe IIH, it will not be as acute form. It might be subacute maximum.
Subacute and the chronic forms.
Yeah, exactly. Supposed to be chronic rather than acute. Maximum, you can say subacute. But it will not be like acute. Acute means something rupture. I mean hours. Rupture of vessel and subarachnoid hemorrhage, intracranial hemorrhage, stroke, massive infarction. All this cause will be as acute onset. But our case here talking about subacute. So space occupying lesion, one of them, it's still meningitis. Yeah, some meningitis.
Cerebral venous thrombosis also.
Yeah, I agree. Venous sinus thrombosis, cavernous sinus. That's why the question of Dr. Mahi was okay to ask about dental procedure, but I need from Dr. Mahi to be more organized while asking the questions.
مش والله اصل النت لما قطع كده
Yeah,
لخبطت.
I think so. I think so. There was some delay and lagging. Anyway, if you ask analysis of the CNS, at least you will address the driving initially, which is very important in this scenario. Patient is driving, having already diplopia and papilledema. She cannot drive at all. Don't wait till the end to tell you, doctor, what am I about my job? It's not a concern. This is advice before being.
Because this patient will be admitted يعني urgently.
Even no, it's not a matter of admission. Of course, will be admitted, but this is not addressing. Maybe she will admit for hours, then she will sign DAMA and she will drive her bus and she will have accident. It's not the answer. It will not be like this. I will admit this patient. Okay, but you didn't ask for the further plan. Maybe she will go out, discharge, improve the headache. She will tell you, doctor, I'm fine. I can go back. I will go to my kids. Then she will again practice her job. So you have to ask about driving, particularly with headache.
Yes.
Okay. So do it as a habit. CNS analysis with headache. You have to do. Any question you are asking as systemic review, the headache and the vision, right?
Yes.
Add to them the hearing, the weakness, the pins and needles, and of course in this scenario, the seizure or abnormal shaking. You ask this question, but I think you ask it later. And neck stiffness, you ask also this question. So don't be confused. Do analysis of the system, relevant system, or the system related to the complaint, which is the CNS in this scenario. Then ask the constitution symptoms. Already you gain some information about hair weight, gaining weight, so it's related to maybe body mass index, something related. So IIH is still possible. Finished the constitutional symptoms. Now the time to ask about past medical history. She told you I have migraine. Address the migraine. What about the migraine? Is it controlled? What medication you are taking? Good to ask about medication overuse headache. However, it will not be as severe headache. Medication overuse, it will not be 10 out of 10. Anyway, it's good to analyze and to address it. Then the past medical history finished. You ask for surgical, procedure, dental. Try to make it as bundles or package of question. Don't make it as disturbed question or from here and there randomly asking. Ask them in regular manner. The past medical history, the surgical history, the allergy, medication list, all this may try to make them as once. Systemic review, at least
In this case
the
يعني برضه to exclude
Mhm.
البوليسيستيك with very aneurysm should start also يعني أو
Okay,
be in first 5 minutes يعني. I think this is
okay,
my opinion.
okay. Yes, I agree with this. But how to analyze and how to address the polycystic kidney in your questions? What do you
يعني
think?
family history of kidney
So
problems.
it will come in the family history. Put everything and the time. I mean, better to be organized. I will tell you now, if you ask about any change for the water work, you will get also polycystic kidney, right? Any change, what for example, for any blood, any frothiness, any kidney problem. If you didn't find anything in the renal system here, you can ask about family history. Any family history, by the way, if there is polycystic kidney disease and you ask any family history of note, in the exam they will tell you. They will not hide you. They will not hide this information, I mean, okay? So they will tell you this, there is family history of kidney failure, for example. He asked good question also about any headache in the family. So maybe the father will have ICH, for example. It will be also clue for polycystic kidney. They will not hide these things. If they want to point to polycystic kidney complicated by subarachnoid hemorrhage, they will give you clues to reach to diagnosis. But if you don't ask these clues, they will not tell you. One of these clues, for example, a family history of stroke, family history of sudden death, right? Kidney failure and dialysis. You will find some of these clues. They will not hide such important history. And as I said, always the surrogate in the exam, he will try to give you the positive related to the symptom. If you ask related to the case, if you ask, he will tell you. But don't wait for him to be volunteer to tell you. At least scratch the area of the branch, then he will tell you. Okay, family history, as mentioned, you have to ask about travel. It's okay to ask maybe history of infection, medication already asked before, medication overuse, cocaine, HIV. Here, okay, you can ask for the cocaine itself. Cocaine can cause headache, right? Spasm and so on. But I think also it's not the case. It will be for as subacute headache. I mean, it will be what we have here, IIH. Do you question? Do you smoke? Do you drink alcohol? And the last, the job and driving. Then examine the patient. How about this approach, Dr. Mahi? I'm trying every time to put it. I don't know. Is it easy or difficult to follow? I don't know. But I feel you are lost. Maybe because of the connection, right? But anyway,
So
try to
this
apply
case,
it.
mm, I proceed for this case as acute headache. So I wanted to rule out meningitis first and the subarachnoid hemorrhage. But I went back to the history and medication, and then I remember and go back to the subarachnoid hemorrhage and the sagittal sinus thrombosis or cerebral sinus thrombosis, thrombophilia scleri. But when I asked her, show me your medication list, she said only paracetamol. Then when I asked later on, she told me I use medication for acne. So I become more confused for this issue. She did not give me the clue from the start medication history. It can help by this
Don't
medication
ask
for the acne.
only what your medication you take. You can tell her, show me your medication list.
Yes,
Then it
yes.
will show you. But if you
Mm.
said you are taking any medication, she'll tell you, I have taken paracetamol. You can ask any other medication or show me your medication list. Put it as a habit to ask about the medication list. Believe me, in the exam, you have a lot of medication and they want to distract you by this medication list. So at least you have to have the finding related to the medication list and to roll out the distractor. Be smart and take the only medication related to your condition. For example, in this scenario, you will see the tetracycline, for example. And sometimes it would be in the past. I took the tetracycline in the past week. So she's not required to tell you I have taken this medication unless you ask for any infection or acne if you suspect, right? And you have to suspect IIH in just such age with this manifestation, body mass index. I think it's already pathognomonic for the case that she has this finding, which is if you link together, you will find it might be IIH.
Mm.
Any question, Dr. Mahi?
No, thank you, sir. Thank you.
Okay, I have also one advice for you.
Yes.
If you want to answer or address medication the patient is taking, don't stop it by yourself, right? If you have, for example, she told you told her, please stop. I think the tetracycline or what?
Yes.
Yeah,
Vitamin.
as precipitating factor. Okay, she will tell you, doctor, I am taking this for my acne. So better to refer her to the skin doctor along with our team. They will address you and give you the proper management plan or the proper medicine. Some examiners they will not accept to stop medication by yourself. So the best answer is to hold, not to stop. Okay, it will be stopped, but as after opinion from the specialty. The same for birth control pills. You will stop her birth control pills. So who will give her another medication? Again, we will go back to the specialized, the woman doctor. She will give her another way to protect her sex, for example. So you have to refer and to hold, or hold and refer. Don't stop and say, I stop this medication. He might tell you why you are stopping. Are you the one doing all this action alone? No, I am referring to the specialty. But before that, I will hold as the trigger of this headache. I will hold this medication. This is the best answer in any medication trigger the disease. Okay,
Okay, sir.
do it as a habit in any question, in any scenario. Say it. Although it's logic to stop the medication, but again, maybe this medication, if stopped abruptly, it will lead to complication. Maybe the patient already improved on this medication. So the best answer is to hold, and I will refer to the specialty to address this issue. Any concern or question, Dr. Mahi?
No, sir. Thank you, sir.
Okay, anyone
بس
has...
أكتر
Yeah,
التريتمنت بس ما سمعتوش من الدكتورة ميادة. آه she was يعني
yeah, don't
not
forget acetazolamide, carbonic
steroid.
anhydrase inhibitor. Yeah, steroid,
Um,
one of the trigger, and the same time, one of the management plan. But
yeah,
acetazolamide, carbonic
acetazolamide.
anhydrase inhibitor, yeah, one of the medication. And always, Dr. Mahi, start as non-pharmacological counseling, education, the association, complication, driving, birth control pills, all these things show the examiner that you are safe. Giving advice is not only giving medication. The doctor is not to give medication only. Okay, pharmacist can give prescribe medication, right? But the doctor who knows the diagnosis and how to address and how to advise and counsel. This is the physician, the safe physician. Then you can talk about the pharmacological. Finish the pharmacological, there is also surgical option. In IIH, there is surgical option in the form of, as you said, repeated lumbar puncture, VB shunt, or optic nerve filtration. If you do the answer in this way, believe me, you will get the full mark in the clinical judgment. But if you start to say steroid, acetazolamide, maybe the lumbar puncture, it's like irregular and disorganized way of management. Please remember the non-pharmacological and pharmacological. The same way under investigation. General, specific, bedside, imaging, invasive test. Even no invasive test, but it's always option to do invasive test. What do you think? There is any invasive test in this scenario? In the investigation?
No. Lumbar puncture can be done.
Yes. So if you put it exactly,
Mm.
I mean everything or every condition or every disease, if you follow this investigation, you will find something in every step. General, blood test for what? In CRP, inflammatory marker rule out infection. Leukocytosis. Okay, this is as general. Liver function, kidney function. Specific in this scenario, what do you think specific investigation in this scenario?
Yes.
Maybe you can say, I don't think there is a specific test here because this is the specific test, lumbar puncture. Okay, bedside test. What bedside test you can do? It's very important. And you mentioned in the examination.
Endoscopy.
Yes, exactly. Yes. Fundoscopy, why? Check for papilledema. Okay, urine dipstick, maybe as Dr. Ala, I think, said it could be polycystic kidney disease for blood and urine to rule out polycystic kidney disease association. Then the image of a choice here, what you will start with? The image. Dr. Mahi. Okay, you'll start with the CT brain to check for dilated ventricles. If you need more advanced investigation, you can think about other MRA, MRI, if you suspect venous thrombosis, for example. Then the last invasive test here is the lumbar puncture, as you mentioned. Any question from others or Dr. Mahi or Dr. Mayada? Any suggestion?
Thank you.
No, thank you.
Okay, open discussion. Can you write your scenario, Dr. Mahi, for Dr. Mayada, and we'll open the discussion?
Okay, see.
Dr. Aisha, you want to add anything here?
No, I think they cover, but steroid is first time only. Using
So we cannot hear you, Dr. Aisha, so far. Again, please.
I said you mentioned everything, I think. Just the steroid, the first time I hear that there is role in idiopathic increase.
Yeah. They are telling it as something weird. Steroid can cause the IIH, and in the same time, it can manage IIH. It's like a funny thing to mention it in the investigation as a trigger, and in the same time, you are saying it's treatment option. Remember in this way, I mean.
Mm-hmm. Yes. I don't know if in examination he checks the neck stiffness and the Kernick sign like that.
Yeah, he mentioned. But it's important, you're right.
Yes, okay.
Yeah, Kernick sign, neck stiffness, as a question in the history and as examination step, he should do it. And he mentioned it, I think. But before
Yes.
doing it, any pain?
Yes.
Okay, any advice or suggestion by?
No, I think you cover all.
Okay, thank you, Dr. Aisha.
Thank you.
Second scenario, 30 years old, presented with weight loss. The vitals, blood pressure 170 over 95, pulse 88, saturation 99. I guess this is male or female, Dr. Mahi?
Female, sir. Female.
Female? Okay. Dr. Mayada, 2 minutes. The same, Mrs. Julia. Let's change the name, Julia Smith. Anyone has suggestion? Someone was talking and giving some suggestion. Dr. Ala, you are the one or another doctor?
I did only
Yes,
one
Dr. Ala?
suggestion.
Yeah, yeah. Okay. Any question now? Any suggestion? Let's discuss together. Till Dr. Mayada will be ready. You want to add something?
No, you covered it all.
Okay. Great.
Okay.
Again, I will share the approach or the causes of headache in bases. I made it as a message and always I am sharing them. Remember how to categorize the headache in bases. You have four categories. The major one, is it with increased intercalated pressure or with no increase in intercalated pressure? So you have, this is the major first two arms, either increase intercalated pressure or without increase intercalated pressure. Then under each category, you will divide again. Is it acute or chronic? I will share it now from the message. You can read it together. But easily, the causes of increased intercalated pressure, maybe they are the most common in paces. Why? Because it's alarming. It carries a risk of increased intercalated pressure. So you have to admit the patient. You have to investigate. You have to manage immediately. What are they? Subarachnoid hemorrhage, meningitis, space occupying lesion, and cavernous and venous sinus thrombosis. These are the causes of increased intracranial pressure or a headache with an increased intracranial pressure as acute. Okay, but some of them, like space occupying lesion, you can consider it acute on top of chronic, but still it's acute one. For the chronic, and this is also common in bases, there are three common headache with no increase in intracranial pressure: the migraine, the tension headache, and the cluster headache. They are chronic, not acute. Okay, we already finished the acute. These are the chronic form of headache with no increase in intracranial pressure. So you will find patient coming with headache frequently, and according to the nature of the headache, you will know what the case. For example, migraine headache, it's throbbing headache. For the cluster headache, you will find the headache comes in attacks with tearing and some eye and nasal stuffiness, red eyes, and it comes frequently according to the patient habits. These are the second, or this is the second cause of chronic headache with no increase in the care pressure. So the migraine, cluster, medication overuse headache, and tension headache. Medication overuse headache, as Dr. Muhi asked, it would be more than 15 days for paracetamol for 3 consecutive months, or more than 10 days for opioid for 3 consecutive months. Patient will take them for a long time. Uh, Sorry? Okay, the tension headache, patient will come with tension like headache, and he will describe for you. He will describe for you that the headache like something over my head, like band like headache. Okay. The other causes of headache, it's not commonly coming in basis, but I will share them in the message in the group. Like hypertensive encephalopathy, it can be. Like pheochromocytoma, it can be also association with other finding of pheochromocytoma. But what I mentioned as a CNS headache, it's related to the CNS itself. By the way,
Also, giant
yeah,
cell,
sorry?
giant cell arteritis, temporal arteritis.
Yeah, this one will come with polymyalgia rheumatica, but it comes also as a headache. But you will find the finding of polymyalgia rheumatica. You're right, and you might have also vision problem or sudden vision loss. Okay, good to mention them, and it will be in specific age group, 50 and above,
More
because this
than
is
50.
exactly this is specific for polymyalgia rheumatica, specific in this group and female particularly. Tension headache also you can find it as association with irritable bowel syndrome. So the patient will have stress, and the stress will lead to these headaches. It's a big topic in PACE is the headache, but how to approach, how to analyze, how to get the clue. I will resend the message again. All causes of headache you will find in. Try to train how to get, how to ask about everyone, put a question, and I will try to make also a short video for the headache because it's very common. Ready, Dr. Mayada, to start?
Yes, you can start.
Okay.
Sorry, the name of the patient again?
Julia Smith,
Juliet.
30 years old, presented with weight loss, head blood pressure 170, over 95, pulse 88, saturation 99. Here you go.
Okay. Hello. My name is Dr. Maida, one of the medical doctors. Can I confirm that your name is Mr. Juliet Smith and you are 30 years old?
Yes, I am doctor.
Okay. What do you want me to call you?
Yes, Miss Julia.
Hi, Miss Julia. Can you tell me what's brought you to the hospital today?
Actually, doctor, over about 6 to 7 months now, I feel my weight is decreasing.
Mm-hmm.
And I feel hot also. One time I checked my body temperature, it was 37.5.
Mm-hmm.
And one time 37.8, like this.
Mm-hmm. Okay. You tell me that over the last 6 months.
Yeah.
How many stones of weight you lose?
About 2 to 3 kilo in this period.
2 to 3 kg. Sounds significant. Uh, is it intentional or you non-intentional one?
Unintentional, doctor.
And what about your appetite?
My appetite is okay.
Your appetite is okay. Okay. Apart from that, over this period of time, you said that you feel hot. Do you have any uh, palpitation? That means awareness of your heartbeat.
No, no,
You didn't. Okay. And you are no awareness. Sorry, again, you don't hear.
no awareness. No awareness of my heartbeat. My heart is okay.
Mm-hmm. Okay. And do you observe any other change, like
Like what?
feeling that flushing,
Feeling
flushes,
what?
flushes?
Flashing? No flash.
Okay. Do you feel any apart from this? Do you have any change in your bowel habits?
No, my bowel habit is okay.
Okay. Do you have any headaches?
Sometimes, yes, I feel headache, yes.
Mhm. Uh, when you say sometime, is it frequent?
Frequent headache?
Yeah. Is it? I understand that it's sometimes okay, but is it frequently?
No, not frequently. Not frequent.
How can you describe your headaches?
It is in all my head and it's a score about 3 by 10, like this.
3 by 10. I also understand that you have high blood pressure. Can you tell me when last time you checked your blood pressure?
Last week.
Last week. Is it the first time to check your blood pressure?
Yes.
Okay. And it was very high.
Yes.
Mm-hmm. Okay. Apart from that, can you tell me, do you have any weakness?
I have what?
Weakness, generalized weakness.
Yes, I feel tired all the time. These 6 months, I feel tired and all the time. I feel this tired and it is worsening with from day to day.
Okay. Is it new, this tiredness,
Over these 6 months.
over these 6 months? Is it increasing or the same?
Yes, it is increasing. Yes.
Do you feel any tremor?
Any what?
Tremor, like shaking,
Shaking of my body? No shaking of my.
shaking of your hands?
No,
Do you feel, what about heat? Uh, do you feel that you are more susceptible to heat or you love cold weather?
no weather difference.
hmm Okay. Uh, you told me that you have headache and you have no you feel just fatigue, but there is no specific weakness in your body.
But you don't have what upon your body?
Weakness, weak.
Yes, I feel weak. I feel weak. All my body weak.
Do you have any pins and needles?
Lack of energy. No pins and needles.
Or loss of sensations?
No, my sensation is okay.
Do you have any problem with the vision?
Yes, I feel blurring of my vision, and mainly in the left eye.
Okay. Any change in your appearance of your eyes?
No, my eyes are okay.
Okay. Do you have
Yeah,
any? Mhm.
yeah. But sometimes when I read a newspaper or read in the book, I feel my left eye is not good. But this
Uh,
comes, but this comes and goes.
okay. When you said not good, what do you mean exactly?
No specific time. I
No, I mean,
feel my vision acuity is not
mhm.
good in the left eye from time to time. Yes.
Do you ever feel like double of vision?
No double vision.
No double of vision. Okay. Do you have any change on your? Do you have any feeling sick or being sick?
No,
Any difficulty with swallowing?
no, my swallowing is good.
Any change in your bowel habits?
No, my bowel habit is okay.
Okay. Any change in your water work?
No, my water work is good.
Okay. Yeah, do you you said you have no palpitation. Do you have any short of breath?
No,
Okay. Any cough or any
no cough.
chest pain?
No cough.
No, and no chest pains.
No chest pain.
Okay. Uh, you said that you have no frothy urine as well.
No frosty.
Okay. Can you tell me, do you have any illness I should be aware of? Any past
I
medical?
don't I don't have any vast medical history. I'm still young, 30 years. But this blood pressure is very strange for me.
Mm-hmm.
I don't know how. Maybe the machine is not good. I'm not sure for that.
Mm-hmm. It's strange, and we are here to find out what's causing it. Do you have any family history of note?
I'm adopted, doctor.
And can you tell me what do you do for a living?
I am a secretary.
Okay. Do you smoke?
No,
Mm. What about alcohol?
I'm not drinking alcohol at all.
Okay. I may need to ask you some questions. I think it's private questions. If you are okay.
Yes.
Mm. Do you take any illicit medications?
No, never, doctor.
Mhm. Can you tell me about your cycle, your period?
Period?
Yeah,
My period is
and
okay. It is
and
regular. Yes, it is regular. Yes.
regular and the amount.
Amount recently it become scanty, but it is still present.
Mhm. Okay. So I will examine you, and I may need to ask you some question while I'm examining you. Is that okay?
Okay.
I will start first. I will ask about the vital sign.
Okay.
Mm-hmm. Anything?
What you wanted to say? What you wanted to check?
I will check the blood pressure in both arms
In
and
both arm?
in both arms. Yeah.
Yeah. In the left arm, it is like outside 170 by 95.
Mm-hmm.
But in the other arm, it is 150 by 80.
Mm-hmm. And then
This is the pressure. Okay.
150 over 80.
Yes.
Okay. And then I will examine, I will ask for the lower limbs as well. The legs. Is there
Normal. Blood pressure is the lower limb is normal.
normal 150 or
No, 180, sorry, 120 by 110. 120 by 70.
okay, then I will check the pulse for tachycardia. If there is any tachycardia.
Where you will check?
In both arms. I will check in both arms.
Okay. In the left arm, pulse is normal, like outside, but in the right radial, it is absent.
Absent pulse.
Yes.
Okay. Then I will temperature and everything is normal. Temperature and oxygen sat.
Temperature is 37.4.
Mm, okay. I think I still need to examine the orthostatic blood pressure in this lady.
No,
There,
it is normal. Normal.
okay. And then I will examine the hands for sweating, if there is any sweating in the hands.
No sweat. No sweat.
And I will examine for tremor.
No tremors.
And then I will examine the face of this lady.
Examine what? Examine what?
Her face. Now I'm examining the face. I'm looking
Gait.
face. Her face.
Face?
Mm.
Yes, face is normal. What you wanted to look in the face?
Then I will examine the eyes, looking for sign of anemia, jaundice, and then I want to examine the visual field of the visual field.
Visual field is normal and no anemia, no jaundice.
Okay, I want to look in the eyes if there is any sign of thyrotoxicosis.
No cytotoxicosis.
And she said that she has double vision.
No double vision. No double vision.
Then I will offer to examine the visual acuity. And
Visual
the
acuity is normal. Normal.
fundoscopy.
Dr. Maida, if you can speak loudly a little bit.
Fundoscopy. I will offer fundoscopy.
Examiner told you no need.
Okay. Then I will go to examine the chest. I'm looking for, I will examine the cardiovascular, looking for any pyruvate or
Where you will put a stethoscope? Where?
in the aortic area.
First aortic area? Aortic valve?
Yeah, first and second aortic area.
There is no murmurs. No murmurs in the
Okay.
aortic area.
Apex.
Where? Apex?
Yeah.
No murmurs. No gallop. S1 is normal. S2 is normal.
Okay. And then I will examine the tricuspid area.
Tricuspid area is normal also.
Mm-hmm.
No cytoplasmic failure.
Okay. I will then complete the examination of the lungs by basal, looking for any biphasal cardiac.
No crackle. Clear
I will
lung.
go down. I will go down to the abdomen. I will start by palpitation for organomegaly and
No
palpate.
organ. No organ. No organ.
Then I will listen to abdominal puree for the renal arteries, stenosis.
Yes, but not present, absent, no Berwi, normal.
Normal. Okay. And then I will
Yes.
go down. Okay. I will go down to examine the refluxes, just to complete for brisk reflux for hyperthyroidism. If there is anything,
Any what? Sorry again, please.
I will examine reflux, looking
Reflux?
for refluxes.
Reflexes, yes. No, reflexes are okay. Normal reflex.
Okay. Uh, then I will. Okay. What do you do for living?
I am secretary.
How this affects your daily day-to-day life?
Yes, doctor, I very tired, lack of energy all the days, and many times I absent from work.
1 minute left.
For that. Can you tell me what's your concern?
Yeah, really, doctor, I am very concerned. Why I feel weak? Why my weight is decreasing? My fever is, body temperature is rising. And I wanted to tell you one time also, I cannot work by my right arm. I don't know why. I feel weak. Yeah, the weakness increase in my right arm.
I'm so sorry for that. We are, yeah, I think from the taking history and from examining you, we see that there is change in the blood pressure in both arms, and this can happen with your symptoms and your headaches and everything. We think that it may be related to change in what in a condition what we call coarctation of the work.
Okay. Hello? Hello?
Yeah, I think she has got disconnection and time is up.
No, me or here.
No, here. We can hear you.
Okay.
Already time is up.
Give her 1 minute to address the concern.
Yeah, suppose this patient name will be Jung Bing Bong.
Okay. Yes.
By the way, suppose
Very,
to be
very common there.
yeah,
Yeah.
characteristic face and characteristic name. You have to name the patient earlier as Asian patient.
Yes. Should be like this.
And the exam, by the way, it will be like this: female, Asian, and middle age.
Mm.
I don't think Dr. Mayada reached diagnosis, but we'll wait for her.
She said quark teacher. Mm.
Sorry.
Hello?
Yes.
I was okay. Wait.
Okay. The examiner question because time is up.
Mhm.
Okay. Dr. Mayada, what is your diagnosis for this case?
مباشرة كده. Okay. I present it, sorry.
Yeah, better
Okay,
better
present.
to present. When you
Okay,
present,
okay.
sometime yeah, you change your mind in the diagnosis. So present your case.
Present your
Okay.
case.
So this young lady presented with high blood pressure and weight loss, which is over the past 6 months, associated with headaches and no change in her appetite, no intentional. She had a history on examination, positive finding that there is a change, difference in blood pressure in both hands, in both arms, and there's no other change in the examination. From the examination and clinical finding, I'm concerned about coarctation of the aorta as a cause of her case. The other possibilities which I can include in this case is hyperthyroidism. Again, which is not all the prior the parameter of hyperthyroidism is not there. I also include the what we call pheochromocytoma. Also can be a differential diagnosis in this case. This is my differential diagnosis.
Okay, so what you will do for this case, Doctora?
Okay. I need to offer for her a investigation, including general investigation, and specific investigation will be for targeting thyroid function test, DSHT4, plasma, a pheochromocytoma screen. I will do serum cortisol for her and dexamethasone suppression test. Also, I will do plasma aldosterone and renin ratio. Renal function test, if of course, and bedside urine analysis. I will do Doppler for NCT angio.
Doppler for what? Doppler for what? Doppler for renal
renal.
artery? Oh,
Renal.
okay, okay.
Oh, I
Yes,
didn't
okay.
hear Biruia.
Okay, okay.
I will do Doppler for her.
Yes.
And CT angio.
CT angio renal? CT angio renal? Renal artery or CT what? CT angio for which part of the circulation?
For the ascending aorta.
Ascending aorta, yes, okay. Okay. What you expected from this test to give you? CT angio aorta?
It shows if there is coarctation.
Ah, yes, for coarctation. Okay, okay. What else?
This is
You will do inflammatory markers, yeast cell selective protein.
inflammatory marker. Yes.
What you will find? Yes.
If I am suspecting, I'm not suspecting anything with this inflammatory marker, please. Okay, I'm not suspecting something with the inflammatory marker.
It will be normal or high?
In the case of coarctation of the aorta, I'm not quite sure.
It will be normal, huh?
Most probably, I'm not quite sure.
Yeah. Yes. So, what is the treatment for this case? What you will do for this diagnosis?
Okay, according to Waya, it doesn't sound to me like congenital because this recent happened. I will see it's surgical treatment if there is a coarctation of the aorta.
Okay. May I ask you, Dr. Mayeda, if you join the symptoms with each other, do you think coarctation of aorta causing fever, causing weight loss, causing headache,
He didn't mention fever.
blurring of vision? Yes, 37.8, sometimes 37.5, 37.4, low-grade fever. And so, do you think a coarctation of aorta causing these constitutional symptoms?
No.
So, if I give you
one of the differential good like pheochromocytoma.
okay. But do you think pheochromocytoma causing discrepancy in the blood pressure in the upper limbs and lower limbs?
No.
Or from right arm to left arm?
No.
So, if you think again is a differential diagnosis, what do you think?
Not yet.
Read the name I wrote, Dr. Mayad. I wrote the name for the patient. I changed the patient name. Suppose this patient name is Jong Bing Bong. What do you think the diagnosis will be now?
From Taiwan, huh?
Taiwan.
Yeah. The name is not in my mind, but it is KSF.
Okay, yes.
Yes, correct.
Okay. Yeah. Okay. Well done, Dr. Mayad. Let's hear the comment from Dr. Mahi, then I will comment.
Yes, if we proceed for this case, this patient first has constitutional symptoms, weight loss, night fever, night sweating. So this either chronic infection or vasculitis or malignancy. Malignancy is less likely in this age. So remaining is infection and vasculitis. But you think this infection take about 8 months like this, and the fever is not so high, and it is mainly in the night associated with sweating also. Then there is discrepancy in the blood pressure from the right arm to the left arm by more than 20. In the one arm it is 170, in the other arm is 150. When Dr. Ameda checked the pulse, she found absent pulse in the right arm, in the right radial, but it is present in the left radial. So this is a clue for the patient. If she wanted to examine more, she will go targeted to see Berwi, auscultate for Berwi in the left subclavian artery and or the carotid artery. Either one of them, it will show there is Berwi. If she did analysis for headache and for systemic review, she will ask, do you have any headache? Yes, I have. Blurring of vision? Yes. Did you lose your conscious level before? She will tell you, yes. I was doing something in the kitchen and I raised my right arm up, I fall down. So I also gave clue in this case during the history that she feel tiredness all over the body, but more in the right arm. This is right claudication, right arm claudication. So all these symptoms are going more with vasculitis. And this vasculitis including ascending aorta branches, mainly subclavian artery. So this case is pulseless disease, a type of vasculitis. There is usually overlap between Takayasu arteritis and giant cell arteritis. Sometimes you cannot differentiate between both of them. It's typical. But the only difference is the age of the patient. Usually, giant cell arteritis is the age more than 50, 55, 60, like this. Also, fever, weight loss, constitutional symptoms the same. Symptoms and signs are the same, but less likely in giant cell arteritis to cause claudication of the right arm. This is the difference. This is only what I wanted to see. يعني
حتى لو
only this
طلعت
what
الحاجات دي كلها
no more
at the end I think I
enough
will
like
not
this. Yeah.
hit the diagnosis because I didn't put in my mind
Yes, yes,
at all. I will never.
Hello?
I agree. Yes, she's saying that she didn't think about it at all. I agree with her, Dr. Mahi, because maybe you didn't hear this topic previously in any session, so you never think about it, Dr. Mayad. But anyway, how to learn from this case? Let's take the home message.
You hear me, sir? You
Yes,
hear
I
me?
can hear you, Dr. Mahi. Yes, we hear you.
Okay.
Okay, so the take home message, Dr. Mayada, whenever you have weight loss, I guess, Dr. Muhi, suppose this patient also the appetite will be low. Vasculitis always like patient lost the appetite, lost the weight, right?
Maybe, sir.
Yeah. The only disease, remember these four disease, you will have loss of appetite with intact or with preserved appetite. Okay, remember these four: thyrotoxicosis and pheochromocytoma and diabetes and malabsorption. Again, the four cause of loss of weight with preserved appetite: diabetes, malabsorption, pheochromocytoma, and thyrotoxicosis. Otherwise, if you have loss of weight with loss of appetite, think about something serious, as you said, Dr. Mahi: cancer, connective tissue disease, or cancer already mentioned, and connective tissue disease or vasculitis. Okay, this is the opposite of gain weight or weight gain. Weight gain, you have to think about, is this weight all over the body or particular areas? This is another approach and another topic. But let's talk now about loss of weight. Loss of weight with loss of appetite, something serious, infection, HIV, TB, or our case, connective tissue vasculitis, and the cancer. These are, in basis wise, you will not find other than these causes. Okay, Dr. Mel? So we put here vasculitis. And again, at the patient age and gender, and also the racial or the race of this patient, you will find this patient is middle age, Asian female, presenting with either absent pulse, or sometimes she will say, I have fatigue, fever for long time, pyrexia for a unknown origin. All this presentation might be with Takayasu arthritis. On examination or in the history taking, you will find either claudication in one arm, the patient will be hypertensive, for example. As Dr. Muhi said, different blood pressure in both arms, headache, vision. I don't know a vision problem here related to what, maybe arthritis also. But anyway, it's major vessel. Takayasu confined to the major vessels, radial aorta, renal arteries, subclavians. So you will find major vessel or major artery inflammation, and the patient will be having absent either pulse. Sometimes also it would be renal affection. It might be claudication in the legs, according to the vessel affected. Clear now, Dr. Mayada?
Yes.
Okay, let's talk about the history. Let's analyze the weight loss. And already we mentioned the weight loss with loss of appetite. You suspect something serious, infection. You will ask about constitutional. Before the constitutional, the relevant system for any of these symptoms, it's the same constitutional symptoms, right? For example, the fatigue and loss of weight, you will ask about other constitutional symptoms. In this scenario, loss of weight, so you will ask about loss of appetite, night sweat, which is positive, and night high body temperature, also positive. Lumps or bumps, low lumps or bumps here. But still, constitutional symptoms guide you to something serious, either vasculitis, connective tissue disease, cancer, or infection. Now you will know why and what could be in this age. But suppose if you have the patient name, you will directly think about Takayasu arthritis. Believe me, it will come in this way: patient, female, Asian, and middle age. You will find also by the systemic review, but medical history, she will not tell you anything. She's clear, free, nothing in her medical history. Systemic review, you will find a lot of vague symptoms like headache. Okay, vague. We mentioned already the fever, and you have to analyze the fever, when exactly, and so on. Let's go back to the systemic review. Headache, vision might be. Palpitation, yes, might be because of vessel affection. She might have dizziness, yes, might be, while standing from sitting, maybe of due to narrowing or the same inflammation of major vessel. I think it's not aortic stenosis, but still the aorta itself. So as Dr. Mahi said, it might be presented with like raising the hand, and the patient will have syncope. So you have to ask also about any syncope or the feeling dizzy. The cardiovascular already finished. Short of breath, nothing, I think. And GI also nothing, unless the patient have vessels affected, mesenteric vessels, so might be as previous surgery to the abdomen, to the bowel. The last is renal. Sometimes they will have kidney shutdown because of also renal affection, renal artery or renal vessel affection. Muscle pain or joint pain, yes, it might be associated, as also vasculitis, so joint pain. Skin rash, it might be associated with any skin rash type of any skin rash. Family history might be positive. And travel, no need here for travel history unless you suspect HIV. You can ask about a question for HIV because here you have loss of weight, so you can suspect HIV and serious infection. The female history, after asking about sexual history, yes, you have to ask because also you suspect infections. HIV is still one of the questions. The period now, the female history. I don't know why the patient will have change of hair period. Dr. Muhi give us the rationale. You said there is scan to be. I don't know. Is it something also related to the vasculature? I don't think it might be affected.
I don't know, but yeah, she asked me, but I don't prepare this answer.
Okay,
But
no problem.
because of the general condition of the patient, this is high intellectual function of the body. So I said impaired.
Maybe because of loss of weight, but it's not classic presentation to be affected as periods, I mean, or female history. Okay. Do you smoke, do you drink alcohol, and do you drive? You have to ask about driving and the job. Definitely, this patient will be impacted by these symptoms. It's vague symptoms, or they are vague symptoms: fever, annoyed fever, fatigue, weak, cannot also do her daily activity. You have to ask particularly about daily activity. Are you able to do your daily activity? Yes or no? No, you have to address it. Okay. I think this is about the history examination, as you did exactly, but remove the coarctation of aorta. Why? Coarctation of aorta, you will have good pulse volume in the right arm, but in the left will be low or absent. But here you have absent in the right? Because the coarctation narrowing after the.
coarctation بين الأبر واللور
Okay, this is another, yes, another point.
بين الأبر limb
Yeah,
واللور.
there is delay of the, yes, I agree. Thank you, Dr. Marwa. But also the coarctation might be earlier than the left subclavian, so the patient will have different also from the right to the left. But suppose also to be there is delay between the upper limbs and lower limbs. And you can also do auscultation of the back for machinery murmur. This is for coarctation of aorta. But in our scenario, the pulse is absent in the right arm. Absent totally. It's not weak, it's absent. So there is something weird. Inflammation of the artery or thrombosis or occlusion of the artery itself. I think nothing else to be examined. Lymph node, yes, you have to examine the lymph node, the cervical, and in the abdomen, you can, yes, as Dr. Mahi said, renal berui to auscultate for renal berui. The femoral pulse, you have to palpate it as well. And to offer blood pressure in the upper and in the lower limb, as well as in the right and in the left arms. Okay. Any question, Dr. Maya?
So,
investigation
Investigation?
for this.
Yeah, you mentioned good way, general. In the general, you will find increase inflammatory markers, ESR very high, right? CRP, ESR. Otherwise, maybe anemia of chronic disease, maybe kidney function will be impaired. Specific here, specific test in this scenario, you can say the inflammatory marker is specific. ESR is very diagnostic in this scenario. The bedside, it's urine dipstick, ECG, echo, chest X-ray, also for the lung, and echo as well for the diagnostic one. If there is coarctation, sorry, not coarctation, it will not be diagnostic as echo, right?
angiography, I think. Angiography.
So, yeah, now for the image. Image is the test of choice or the radiology of choice. You go and geography, and it will show you the vessels affected, either radial, subclavian, aorta itself,
But on geography, as
Angio,
it will
like
be
Dr.
total,
Mayeda said,
more.
CT angio is a diagnostic
total.
test. CT angio.
Yeah,
CT angio, as Dr. Mayeda said, it will be the diagnostic
What
test. Yeah.
exactly the city angio? I will ask for which area.
any vessel. No, no, all vessels. You might have multi-vessel affection.
Mhm.
Aorta itself, it might be affected.
Yes, but in this vessel,
Biopsy also
in
the
this
definite.
CT
Sorry.
angio, it was narrowing of the
Biopsy is
uh,
with a definite
branch.
diamond.
Yes, biopsy for
branches.
the artery. This is as invasive test, biopsy.
Yes.
Yeah, biopsy for
It's
the
a middle
artery.
artery arteritis, so the vasculitic screening will not be positive, yeah?
The ANCA and B ANCA, you mean, right?
Think this will be negative.
Yeah, suppose is not the case, yes. But ASR inflammatory markers are positive. But other ANCA, I think it's not. I'm not sure, but I don't think it will be positive.
Because yeah, it's medial vasculitis.
Yeah.
And what else? The treatment.
Treatment, as you know, and I guess you will know, and is a pharmacological, of course. Apart from non-pharmacological, what do you think the pharmacological option?
Hydrocortisone.
Steroid. Don't specify what. Yeah, don't specify hydrocortisone. So steroid only. They don't need to give what steroid and what type of steroid you will give. Just and it will be high dose pulse therapy. By the way, okay. I'm not sure. Is it 500 milligram or 1 milligram per kg? Dr. Muhi, did you read it? Is it 1 milligram
No,
per kg or one gram or pulse therapy as 500?
والله what I read steroid, then steroid
Sparing,
um,
sparing agent.
agents, yes,
Yeah.
methotrexate and
Yeah. Okay.
glufosinamide like this.
So I will give you this homework for Dr. Mayada. What the dose of steroid in Takayasu? Is it pulse or just high dose, 1 milligram per kg?
Okay.
I wanted to tell also no need for biopsy here, vasculitis, because if we do CT angio or even angiography in general,
It will be
such
diagnostic.
as
Mm-hmm.
yes, you will see in the diagnostic it is narrowing, including the carotid, subclavian, and it is diffuse narrowing, not atherosclerotic. Atherosclerotic is localized or focused, but here diffuse narrowing of the all branches of the aortic arch. It is diagnostic
Yes.
without any. Okay.
Yes. Okay. Carotid
Okay.
also need examination.
The homework. I did it. Prednisolone 1 milligram per kg per day.
Okay.
The maximum 60 milligram per day.
Okay. So it's not pulse. It's just one a high dose of steroid. Perfect. Methyl
I
prednisolone.
guess if
1 milligram per kg.
vision is جيورد يعني at that time we can increase the dose too much يعني. Vision,
If the
giant
vision
cell
is affected,
arteritis.
as the giant cell
If the
arthritis.
vision is يعني affected or at the risk, so at that time we
Okay, noted, Dr. Mahi. Thank you, Dr. Mahi. Any
then
other?
tapering.
Yeah, okay, sure. Whenever you mention steroid, try to counsel about steroid, particularly high dose or long time steroid dose. Plus, Dr. Mayada, don't forget the non-pharmacological counseling, education, the complication, association, physiotherapy, multidisciplinary team approach, ophthalmology, cardiology, and here also nephrologists, rheumatologists, clinical pharmacists, and specialized nurse. You can consume a lot of time mentioning these things, which is not the pharmacological. Always the problem and the clinical judgment when you start to mention the pharmacological options. You might say medication or you don't know the medication, but if you start to mention other things, it's good to consume the time, utilize the time, giving option for management, which is not the pharmacological, which is correct. in the basis wise, they need from you to specify the non-pharmacological before mentioning this pharmacological. Okay.
Mm.
So it was a nice case and very unique case. It's very rare, but when it comes, you will be in trouble if you don't remember this session. تكياس وأبتراس.
كومنت بس يا دكتور.
Yes, sure, Dr. Marwa. Start.
الهيستوري اللي كان بين patient described it as generalized weakness and fatigue can make us put other hypokalemic hypertension causes as secondary hypertension يعني in differential and in investigations يعني.
Yes, you are right, Doctora, but no weight loss. In Crohn's disease, there is muscle
not
cramps, muscle weakness.
yes, not the diagnosis but in differential يعني and in investigations electrolytes والimaging abdomen imaging
Hypokalemia, yes.
الهايبوكاليميا اللي هي مثلا الكونز والكوشنج في حاجات تاني في حاجة تاني.
You mean for the lower
تاني
limb, periodic paralysis?
No. The patient mentioned that she has generalized weakness and she has hypertension. اللي أنا بقوله إن إحنا
You
ممكن
can,
نحط
yeah, you mean middle. Cones and middle.
يعني عموما as general يعني اللي هي الهايبوكاليميك hypertension in differential and in في الانفستيجيشنز. تاني حاجة اللي هي I'm not sure يعني from it اللي هي ستنت في المانجمنت بتاع التكيس أو الفيزلز replacements يعني they included في المانجمنت either stent for stenosis أو vessels replacement يعني.
Perfect. Yes, it's one of the surgical option here. Perfect. Stenting. Yes, thank you, Dr. Man. Perfect. Thank you, Dr. Marwa. Any other suggestion?
ما سمعتش انا يا دكتور باسم بتقول ستنتنج لمين يا باشا؟
narrowed vessels supposed to be stented. You can put in stent to bypass this.
No, cannot be because this is diffuse. We cannot put a stent for more. Any stent maximum length is 48 milli. We cannot put a stent in this vasculitis.
No, it
دكتور
can be.
أنا سمعت النهاردة
Yes, it can
بالصدفة
be.
يعني كلام عن الموضوع
This
ده.
is not atherosclerotic. So stenting
Yes, but
is not issue at all.
the patient was تكيسه and have chest pain and entered for BCI. And doctor said يعني when he start to do the catheterization he find many narrowing and he mentioned that he bought about 25 stent for this patient.
I think stent will be closed. If we put a stent, it will be.
No, the stent will be difficult to be closed. You mean thrombosis to be closed, but this is not thrombosis. This is narrowing from the vessel itself. By the way, renal artery, if involved, they can also insert stent. So it's one of the options, Dr. Mohammed.
I think this is in atherosclerotic only, but in vasculitis, no. No stent in vasculitis because this is inflammation and you cannot. This vessel is very fragile. If you put a stent and you don't inflate it, it will be closed. Even the patient is
maybe
still in the
wrong
catheter.
management by this doctor يعني we can search it.
Yes, we will update. I remember it was one of the night.
It was life-saving procedure just to save the heart. Then they will giving it steroid, and because really the stent here it will not overcome the inflammation, so it will continue to. So I think it was life-saving because he don't know when he did he enter for catheterization. He suspect it is MI.
Yeah, I remember from part 2 there is stenting as management plan. I will try to read and update it in the group.
Maybe for urgent management, Dr. Basim, but I think for long term it is inflammatory process,
Yes, for
so you
long
should
term, but
suppress
for
the
example,
immunity.
Dr. Aisha, if you have ischemia, for example, you have to interfere, right?
Yes, I
Even
know, but
if in
yes,
acute case, يعني consider line of management, even if in acute conditions.
maybe yes.
Yeah, it's not for the long term, but it will resolve the ischemia, for example. If the renal artery is involved, it will preserve the kidney. Otherwise, you will have kidney injury and the patient might have kidney failure because of this narrowing. So you can overcome this or bypass this narrowing by stent.
Possibly the vessel will rupture, Dr. Basim. If you put a stent, it will rupture.
Okay, Dr. Mohiy, I agree that there is inflammation, but let's update it by written evidence in the group to be clear.
Mhm. Okay.
But I remember this in part 2. It's one of the management plan. Okay, Takayasu. I'm searching about it now. Any question or suggestion? Takayasu surgical option. Any question or
No, if anyone have like the vasculitis generally, the small vessel vasculitis, if to know generally about the symptoms, small vessel vasculitis, how it present medium vessel vasculitis, these types of vasculitis.
I
I
think
wrote
Dr.
it?
Maeda just this the first thing Dr. Basim mentioned. When you find weight loss and poor appetite,
No,
you have only
generally.
four option. Four option. If you exclude the others, it is vasculitis by exclusion. Then search. If you reach the diagnosis exactly which type of vasculitis is good, but just to arrive to it is vasculitis because we confused at this level that we didn't find something related to each other. Even and vasculitis is always like that. You find symptoms related to each other. You try to pick up in your mind, and you have limited time in exam, and you're already stressed. And so, if you put in your mind, just it is four things in weight loss with poor appetite. If it is not addition, it is not cancer, it's not chronic infection, so it is vasculitis. Nothing other.
This is not my question. My question is the type of vasculitis. Can someone summarize this for us?
Yeah,
The small vessel vasculitis, the names and the
Berger, I
presentation.
think this is the Berger disease,
Anyone
one
have
of small vessels. Yes.
yeah, this is the types as Dr. Mayada mentioned that the small, medium,
And
and
the
large.
polyarthritis nodosa, it is small also.
Yes, and I think microscopic, right? Microscopic
cholangitis?
cholangitis. This is also small. The
Mhm.
medium, like Takayasu, I guess, and giant cell arthritis. Or Takayasu, one of the major vessels, right?
I think
Giant
Takayasu is a large
large.
vessel. If it is
Large.
aorta, it is a large. Yes.
Yes, large,
Giant,
large.
giant I am more than large.
Mm.
Yeah, large, yes. Large. Takayasu is large.
لا
So
giant cell arthritis.
giant, you mean? Yes, could be
Mm.
also as
No,
large.
no, giant medium. Temporal
Medium?
artery. Yes.
Why
Femoral
name
artery.
is giant?
It is giant because the type of cells when you make in the biopsy, you will find these giant cells in the wall.
Okay.
Okay.
Mhm.
And the other medium will be polyangiitis GPA, right? GPA and eosinophilic.
I think all the good buster and all these small
Yes.
vessels. Yes.
Small or medium?
Only the medium, it is the giant cells because it is big vessels. You will notice and very clear symptoms. But the others, it is small vessels. I think all this.
الكواساكي اللي هو affect الكوروناري maybe large vessels. كواساكي بتاع ال
I
children
think also medium.
medium بس هو affect الكوروناري mainly.
So the
coronary small صح.
Takayasu may be the only one large.
Mm.
we can also make updates in the group. Anyway, I shared in the chat box the stenting here used in conjunction with angioplasty. Renal and carotid and subclavian arteries, more commonly used in. Covered stents may be needed in case of aneurysm. So there is option of stenting, Dr. Mohi.
So I bring also the option of stenting is already there.
Yeah, there is option.
Vasculitis, large cells, Takayasu, and giant cell. Okay.
Okay, it changed now.
What's
Okay.
true giant cells, large?
Giant.
Medium,
Yeah.
medium,
Okay.
polyarthritis, and the Kawasaki. Only those.
Okay. And
All
others are
others
small.
small. All others ANCA positive, ANCA
Perfect.
associated, all small.
Perfect.
I'll share the picture. Okay.
Okay. Thank you, Dr. Aish. Thank you, Dr. Maeda, for this question. It refresh the minds. Any other question, Dr. Maeda, you want to refresh the information?
No, thank you.
Okay,
Nice
thank you.
discussion.
Yeah, it's always
Take the
nice.
vasculitis away.
Perfect. Yeah. Particularly if you don't reach the diagnosis, you will learn more. If you reach the diagnosis, you will just forget it after the session. But if you don't reach, you will read it more and more. Try to focus the next time.
Yeah.
Yeah. Okay. Thank you. Thank you, Dr. Mahi, also for the practice today. Any other question, comment, suggestion, doubt?
Thank you,
And
sir.
raise your voice, Dr. Maya.
Yeah. Try next
Train
time.
yourself to raise your voice.
I think there's something here today's session with Dr. Mayad, but usually she's
But I think
speaking.
she was also quiet.
Today,
Always she was quiet.
Putting the ear.
the AirPod. Yeah.
Maybe.
But usually she's speaking fluently and loudly and clearly. Usually, I don't know today. Maybe there's something different.
Mhm.
Okay. Thank you also, Dr. Raisha, Dr. Marwa. Any question before ending the session? This week will be as long and communication, long and communication, long and communication. So we'll not have short station this week. We'll just do the long and communication alternatively. Okay. So anyone interested, just send me for communication or long clinical.
Okay.
Okay. Thank you, everyone. We'll see you tomorrow, inshallah, with the communication day. Good luck and good night. Assalamu alaikum wa rahmatullahi wa barakatuh.